Welcome back to the deep dive. For this deep dive, Chapter 1, Episode 5, we're taking on, well, a really crucial topic, mediastinal masses. Our goal today is to unpack the diverse ways these show up in radiological imaging, making those complex findings hopefully a bit clearer for you.
Absolutely. And we've got some great sources here. Understanding these specific imaging signs isn't just, academic learning. It's often the key to telling different types of masses apart quickly. A really critical shortcut.
Okay, fantastic. Let's dive right in then, starting with thyroid masses. Our sources mention these are often goiters extending downwards, sometimes just found by chance on a chest x-ray, a CXR. What might a radiologist first notice on that initial x-ray?
Yeah, so on that plain CXR, you're typically looking for a pretty well-defined mass, usually up in the superior mediastinum, maybe anterior or middle.
Yeah.
A big clue can be if it's pushing the trachea of the windpipe sideways, or sometimes even making it narrower.
Right, that displacement.
Yeah.
So after that CXR, what's the next step usually? What does CT bring to the table?
Well, CT is really crucial. It gives such a detailed view of the mass's shape, its exact location. And here's often the clincher. You almost always see the masses directly connected, continuous with the thyroid gland up in the neck. That's key.
That continuity.
Exactly. And on CT, you'll often see what we call heterogeneous enhancement. It lights up unevenly with contrast. Sometimes little flecks of calcification, too.
Okay. And you mentioned scintigraphy.
Yes, scintigraphy, that's the nuclear medicine scan. It can directly show that the mass is thyroid tissue backing up the CT findings.
That continuity point seems really significant. Okay, let's shift to parathyroid masses. These can be tricky, right? Often linked with hyperparathyroidism, and they can be small. How do we even start looking?
You're right, they're often tiny. Plain x-rays almost never show them. Ultrasound US is really the best bet for small ones.
Ultrasound, okay. And what do they look like on US?
Typically an oval, well-defined mass, usually just behind the thyroid. It often appears anechoic, meaning black, or hypoechoic, so darker than the tissue around it. Larger ones might look a bit more complex, maybe multilobulated, sometimes with brighter spots, cysts, or even calcification.
And if ultrasound can't see it well, or for bigger masses, what about CT? What are the unique features there?
CT is great for those harder-to-reach spots. And parathyroid masses have this interesting feature. They often appear denser, higher attenuation before you even give contrast.
Oh, really? Before contrast?
Yeah, it's thought to be due to the inherent iodine content. And then after IV contrast, they show really intense enhancement that lasts for a while. If you see low attenuation, like a darker area, that might suggest cystic changes. And calcification can give clues. Too benign tends to be rounded, whereas carcinoma might look more amorphous, kind of cloud-like.
So CT gives great anatomical detail. What about function? And how hard is it to tell if it's malignant just from the CT?
Good question. For function, we often use 99 milli-TC MIB scintigraphy. The key there is timed imaging. Early on, both the thyroid and parathyroid pick up the tracer, but if you wait maybe 90 minutes or so, the thyroid tends to wash out the tracer.
Okay.
Well, the parathyroid holds on to it much longer. That difference in retention is highly suggestive. But the big challenge is determining malignancy purely on CT. Unless the tumor has clearly invaded nearby structures, it's very tough to say for sure just based on the CT appearance.
Right, that makes sense. Okay, let's switch focus to the thymoma. The sources say it's the most common primary tumor in adults in the anterior mediastinum. What's the best way to image that?
For thymomas, CT is definitely the go-to modality.
Yeah.
Best overall picture. Typically, they look spherical or oval, often with lobulated bumpy borders. You might see some cystic areas, or maybe tiny dots or curved lines of calcification. They usually have a fairly uniform density and enhance evenly with contrast.
Okay, pretty characteristic, but what if it's an invasive thymoma? How does that change the picture on CT?
Yeah. Invasive thymomas look different. The margins become poorly defined. It looks like it's disrespecting the normal boundaries. You'll see it growing into the mediastinal fat, maybe the pleura lining the lung. It might even wrap around blood vessels or spread to the pleura as metastases.
An MRI, does that add anything specific?
MRI can help. On T1-weighted images, it looks similar to muscle. But on T2-weighted images, it usually shows up brighter, with higher signal intensity compared to the surrounding fat. If there's cystic change or bleeding within it, it can look more varied, more heterogeneous.
Got it. So moving beyond thymomas, let's touch on other thymic and germ cell tumors. How would something like a thymic carcinoma differ from, say, a thymolipoma on imaging?
Big difference there. A thymic carcinoma on CT is usually nasty-looking, large, irregular, heterogeneous, often with areas of necrosis or dead tissue and calcification. The fat planes between it and nearby structures might be completely obliterated. A thymolipoma, on the other hand, is benign. It's basically a fatty mass. It can get huge, but it's soft and just kind of molds itself around things. Seeing that fat content on CT or MRI is pretty much diagnostic.
Fatty nature is the giveaway. Okay. And what about mediastinal germ cell tumors like teratomas? What screams teratoma on a scan?
Keratomas usually sit in the anterior mediastinum, often well-defined, maybe rounded or lobulated. The classic CT finding is that mix of different tissues. You might see fat, fluid-filled cysts, soft tissue density, and often calcification. Sometimes you can even see structures that look like a tooth.
A tooth. Wow.
Yep. And again, seeing fat within the mass on CT or MRI is a very strong indicator for teratoma.
Okay. And then briefly, how do the other germ cell tumors like seminomas and the non-seminomatous ones differ?
Seminomas tend to be more uniform. They usually appear as solid, well-defined masses with homogeneous density on CT and signal on MRI. Pretty uniform enhancement, too. Non-seminomatous germ cell tumors, or NSGCTs, are often more complex. They might be more lobular, look more heterogeneous inside, and they often enhance more avidly with contrast than seminomas. Because they can grow fast, you might see those fat planes disappearing again.
It really is incredible how much specific detail these different imaging methods can give us. Each one adds a unique piece to solve the puzzle, doesn't it?
It absolutely does. And telling these masses apart really hinges on recognizing these sometimes subtle, but always critical radiological features. It's not just about spotting a mass, it's about understanding what it might be, its potential behavior, and what that means for the patient.
Exactly. Well said. So, as you listening think about all this detail, here's something to ponder. How might the specific location of a mass within the mediastinum anterior, middle, or posterior give a radiologist some initial clues even before they get into all these detailed imaging features? Keep exploring those nuances. We'll catch you on the next deep dive.